Ordinally, okay.
Okay. So I will share screen. So this is beginning. Can I start? Okay. Hi, good morning, good afternoon, and good evening to all of you, depending on where you're dialing in from today. And welcome to the second mini symposium of the Global Social Medicine Network. My name is Junko Kitanaka. I'm a professor in the Department of Human Sciences at Keio University in Tokyo. And it is my privilege to co-chair today's event together with Professor Francisco Ortega, who is professor at the Institute for Social Medicine of the State University of Rio de Janeiro and visiting professor at the Department of Global Health and Social Medicine of King's College London. We will be sharing the second of two conversations on social medicine from the South on behalf of the Global Social Medicine Network, a Wellcome-funded network that aims to bring together scholars from all regions who are committed to a vision of social medicine as a vital intersection of social sciences, medical practice, and policy. I would like to welcome our network, our panelists, and also colleagues from all over the world who are joining today, many of whom are linked to our network and to sister networks, such as the Social Medicine Consortium and the Medical Health Humanities Africa Network, among others. And I would also like to thank the steering committee of the network who have worked to put this event together, including Professor Vincent Adams, Carlo Kadaf, Jeremy Green, Helena Hansen, David Jones, Francisco Ortega, Nicholas Rose, and myself. I would also like to thank our assistant, Alice Hilborn, for her work as well. So today, we are very fortunate. Let me change the slide. So today, we are very fortunate to have the second of two conversations that center on social medicine as a truly global field. And we use this provocation around the question of relations and relatedness between the contested categories of North and South to foreground the diversity of approaches to thinking and doing social medicine. Today, we will be linking conversations between contexts, including China, Chile, Russia, Taiwan, Iraq, and the US. We will start with an introduction to the Global Social Medicine Network by Professor David Jones. Then Professor Ortega will introduce the first three of our panelists, and I will introduce the last two. The panelists will offer a 10-minute response, and then we will have ample time for discussion. So please do post questions in the chat or note them down, and we will take questions for individual panelists and the collective at the end of the presentations. This session will also be recorded and uploaded on our website, so please do share with your networks as well. Let me hand things over to Professor Ortega.
Thank you, Junko. So let me introduce Professor David Jones, who will offer us an introduction to the Global Social Medicine Network. Professor Jones is a physician and a historian of medicine at Harvard University with research interests in heart disease, cardiac therapeutics, human subjects research, and the health effects of air pollution. His initial research focused on epidemics among American Indians, resulting in a book, Rationalizing Epidemics, Meanings and Uses of American Indian Mortality since the 1600s, published by Harvard University Press in 2004. He has also written Broken Hearts, The Tangled History of Cardiac Care, Johns Hopkins University Press 2013, which examines why it can be so difficult for physicians to determine the efficacy and safety of the treatments. He's now at work on two follow-up books, one on the origins of therapies, will trace the evolution of coronary artery bypass surgery. The other examines the history of heart disease and cardiotherapeutics in India. Thank you, Professor Jones, for your introductions to the Global Social Medicine Network.
Well, thank you. And I'd like to join my colleagues in wishing everyone good morning, good afternoon, or good evening, wherever you happen to be. The Global Social Medicine Network brings together scholars from around the world who are united by our belief that health and disease cannot be understood from the perspective of the biological sciences alone, and that optimal solutions to the problem of disease will require us to engage with economics, politics, and society. One of the interesting things about social medicine is that the field itself has never been rigorously defined. It has taken different forms in different countries, depending on local health conditions, local political considerations, and many other contextual factors. Knowing this, one of our goals in this network has been to identify people working in different social medicine traditions all over the world and to bring them together so that we can learn from each other, whether we are in Brazil, South Africa, the United States, India, or any place else. Part of our interest is academic and involves mapping the commonalities and differences among these different traditions. But social medicine has never been a purely academic field. We are also interested in what it has meant to practice social medicine. Many of the most interesting developments in practice have taken place in the Global South. Now, we are very aware that we are not doing this work alone. Some of us are also involved in the Social Medicine Consortium, a group that has focused on healthcare practitioners. Others are involved in a conference taking part this week, hosted by a group in Vienna, that is exploring the past 50 years of work in the fields of social medicine. We welcome all of these efforts to broaden and strengthen the work of social medicine. Now, the talks that you will hear today continue a conversation that began on Friday. We had 4 fabulous speakers from Zimbabwe, the United States, India, and Brazil, who started many fascinating conversations that I expect will continue today. For example, how do we think about, navigate, and mitigate the enormous disparities of wealth and power that exist on a global scale? This is a particular problem for social medicine, which has long been an implement of colonial powers. While it is convenient to distinguish the global North and the global South, we recognize that great inequities exist within both North and South. Only by understanding the multiple social realities that exist within any country can we bring health to all people within any country. To do this, we have to work against the increasing focus in both medicine and public health on pharmaceuticals, other commercialized technologies, and individual responsibility. Social medicine is a social science. We need to focus attention on the social and economic conditions that are the fundamental drivers of health and disease. We cannot restore health through pills alone, but instead need to rework the fabric of society. And we cannot do this as experts dictating to others. Instead, we need to engage in the public sphere, learn from diverse people, and ally with them to generate political will and collective action. This work requires generous reciprocity and reflective self-criticism. Done in this way, social medicine has the power to transform and improve people's lives. I look forward to hearing now how the talks this morning move these conversations forward. So I'll turn it back to Francisco for the introductions.
So thank you, David, for this excellent introduction. And it's now my privilege to introduce our first speaker. So Xi Ma is an assistant professor at the Crown Family School of Social Work, Policy and Practice at the University of Chicago. Trained as a medical anthropologist, she conducts research on family and community care for people with serious mental illnesses in China. Another line of her research investigates China's emerging disability rights movement and its impact on different disabled communities. Besides her own research, she also actively collaborates with community members and other stakeholders on projects of advocacy and intervention, such as the development of mental health peer support services. Thank you, Dr. Ma.
Thank you so much for the kind introduction. I'm just going to share my screen now. And also just a quick note, because my daughter is being taken care of by her by my mother-in-law, and she might be screaming in the background. Sorry for the interruption. So thank you so much for inviting me to this great mini conference. And I'm obviously going to use my work in China to think about social medicine from the South, think about the provocations of this mini conference. I won't say much about my work because Professor Ortega has already kindly introduced me, and also in the interest of time. And I'm today gonna mainly draw on my work about mental health in China to think about the provocations. But before I do that, let me answer a quick question that you might be asking. That is, why do we even talk about China in a conference about social medicine from the South? Is China even part of the South? Well, this is a very fair question, I think, because China is obviously having a lot of economic prowess nowadays and also flexing its political muscle on the global stage. But I still think it's valuable to think about China as part of the South or in relation with the South, mainly for these three reasons. And those, I think, might be ways we think about the South in general as well. One is that China, of course, has a long history as part of the South. And in fact, processes of colonialism, or what in China people might call semi-colonialism, imperialism, and global capitalism have left many material and symbolic legacies on the country, including its health and social welfare institutions. And even today, China is often treated as the destination rather than the place of departure of many projects of global aid and knowledge transfer. And the second aspect is that if we think about Jean and John Comaroff's idea of theories from the South, that is, people in the South often actively, consciously create theories about geopolitics, about modernity that depart from the Western theories, then, or the Northern theories, then in China, we've seen many such theories from the South, some of which have global impact. And the third aspect is, even if China is having a lot of economic prowess today, we shouldn't forget the fact that processes like neoliberalism, state violence, etc., are actively producing many marginalized communities and locations in the country, or what some might be calling internal Souths. So with that said, let me start to think about social medicine from the South with my work. I'm here gonna give you a very quick look on the history of mental health in China to start us thinking. My first project looks at families' involvement in the care and management of people with serious mental illnesses in the country, and how that is shaped by the country's psychiatric practices and also the recent mental health legal reform. And some of you might ask, well, isn't China a Confucian country? And isn't it naturally just family oriented? Like, why is it even interesting to talk about the Chinese family in mental health care? Well, I would argue, if we think about the first point of China as part of the global South, if we think about the history of imperialism, missionary, etc., we would see that the Chinese family as the very idea of the Chinese family as an unchanged tradition in the care of mentally ill people is actually a construction, a modern construction. It first started when medical missionaries from the US entered China in the late 19th century and trying to establish an asylum for the insane. At that time, in order to justify their efforts, their argument was that, well, look at the Chinese families, they really treated their insane members badly by chaining them, locking them up, etc. And we need to go in and rescue the insane and put them in the asylum to protect them, heal them, and evangelize them, etc. And it's since then that the idea of the Chinese family became so essentialized and important in various ideas of psychiatry and psychiatric practices. And moving on to the socialist era in the mainly in the 1950s to 70s, we see that a lot of people were making conscious theories from the South at that point. For example, people typically understood mental illness through the lens of revolutionary ideologies, such as mental illness as a product of feudal and capitalist social oppressions, and or an obsession with bourgeois ideology, etc. And also at that time, many hospital psychiatrists were launching their local community mental health experiments by going into urban and rural communities, spending much time there, helping to build mental health stations and training barefoot doctors to deliver basic care. And those kinds of experiments were later praised by the World Health Organization as models for developing countries. And as we have entered the post-socialist era from the 1980s onward, we've seen a lot of drastic changes in psychiatry in China. For example, people have largely abandoned the embrace of community care and mass science, and instead aspire for cosmopolitan elite science and also specialized hospital care as the model of mental health care and other kinds of health care. And as a result, we are seeing nowadays a dominance of biomedicine, the use of psychopharmaceuticals, and hospitalization in mental health. And in the past decade or so, human rights activists in China have been vehemently attacking the widespread use of involuntary hospitalization, usually initiated by family members, but sometimes by local governments and work units as well. So in defense of that kind of practice and other measures of coercive care, psychiatrists who drafted the first ever national mental health law try to defend that practice as a form of state paternalism. And they deliberately contrast that with the West sort of obsession with individual autonomy and with deinstitutionalization, which they argue have left many people have brought a lot of crisis to not only the patients, but also the public. So that's another conscious theory from the South, if we will. And of course, the neoliberal state now doesn't really want to commit any financial resources to the responsibilities of state paternalism. So instead, it has shifted the responsibility to patients' families, which in my field work means a lot of intimate injuries within the household, and also a production of an uneven landscape of mental health care across the country. Just thinking back on Professor Jones' idea of how health and wealth disparities have sort of like prevailed in the global South. So finally, very quickly, about how people imagine the future of mental health care in China. We see that, or my work shows that actually a lot of people are invoking, but also critically engaging with various global resources, global discourses to imagine the future. For example, psychiatrists who are also unhappy about the concentration of resources in institutions, and also are concerned about the health disparities, are drawing on global mental health discourses. For example, the idea of task shifting, the idea of a mental health gap, etc., to try to redevelop a community mental health infrastructure. And at the same time, human rights activists, social workers, and other stakeholders are working with people with mental illnesses to try to forge new identities outside of the kind of medical model. For example, survivors, users, peers, etc. And these terms I know might not be strange to people in the North, but I would argue that we need to pay attention to how people critically engage with them. Just a very simple example, the idea of a consumer, which is often also very popular in the North, is quite absent in the mental health discourses in China, because people know that, well, if you don't really have control of what services you get, you're not a consumer, right? So we need to pay attention to those kinds of critical engagements. And very quickly, lastly, instead of a kind of the kind of liberal democratic citizenship that we often hold up as the assumption and destination of healthcare and human rights interventions, we see in China many caregivers and sometimes people with mental illnesses themselves struggling for what I call a paternalistic citizenship, in which people are asking the state to actually keep its words and to be a caring parent for its vulnerable members. So as a conclusion, I think the Chinese case, particularly mental health in China, has reminded us the importance of studying social medicine from the South from various perspectives. One is that it reminds us to really rethink and expand the very category of the social by looking at material impact and symbolic legacies of world historical processes. Just the very idea, like I said, of the Chinese family, it could be a historical construction, right? And secondly, we need to pay attention to theories of health, illness, and disability in this, from the South, and how they diagnose and offer solutions to social ills on individual, but also collective levels. And those theories might offer a lot of inspirations to how we think about social medicine today. And thirdly, instead of thinking about the South as the destination and an unproblematic destination of global knowledge transfer, I argue that we need to think about it as actively and selectively translating global discourses. And in this process, global discourses also get transformed. And very lastly, I think instead of upholding the idea of liberal democratic citizenship as the ideal of various interventions, we need to really pay attention to the variegated ways in which citizenship is imagined, granted, achieved, or denied by people and to people in the South, and to meet people on those terms. Thank you very much.
So thank you, Professor Ma, for the excellent presentations. And we move to our next speaker, Dr. Cristian Montenegro. Is a qualitative health researcher with a background in sociology and health policy. His research focuses on service use involvement and activism, psychiatric disinstitutionalization, and human rights advocacy in mental health. He's an assistant professor at the School of Nursing at the Pontificia Universidad Católica de Chile, and a young researcher at the Millennium Institute for Research on Depression and Personality. He is one of the co-founders of the Platform for Social Research on Mental Health in Latin America, PLASMA. Thank you, Cristian.
Thank you, Francisco. I'm gonna share some slides right now. Okay. Okay, so well, I'm very glad to be here. I'm gonna talk about the creation of PLASMA. I'm not gonna talk about my own work, but about this process of trying to build something that somehow incarnates some of the questions that are posed in this workshop, and I will reflect on those questions as they developed through the creation of PLASMA. As you all know, the call for scaling up mental health services in low and middle income countries, initiated by Euro-American psychiatrists and institutions during the mid-2000s, has received mixed reviews, to put a name. A significant amount of literature has emerged to interrogate the movement for global mental health. Alongside significant gains in mobilizing attention and resources to scale up mental health services in the global South, the imposition of Western modes of thinking and acting upon human suffering across cultures has been especially contested. Despite these controversies, or probably because of them, the notion of global mental health has become an irresistible descriptor of contemporary policy practices and aspirations, and producing an ongoing discussion that involves different voices and disciplines. In June 2016, one such conversation started. A group of PhD students, small group, in the social sciences gathered to discuss and debate their projects on mental health in Latin America. We were moved by a sense of frustration at the difficulties in conveying the specificities of Latin America to researchers based or focused on other regions. This led to creating the Platform for Social Research on Mental Health in Latin America, or PLASMA. Today, I would like to use the example of PLASMA to reflect and rethink the set of relationships so frequently described as North and South. Back in 2016, and as we first met three things became apparent. First, somehow Latin America did not seem to be part of the focus of GMH, or global mental health. At the same time, no Latin American researchers or institutions were involved in the call. Latin America was not in the map of global mental health. Second point, or second question, the social sciences have only had a minor role within this field of study, with epistemological and political questions hardly considered in the main calls for actions and research, and with a very thin conception of social contexts and processes. Third point, this lack of contextual depth could partly explain the limitations of the map, the fact that Latin America was not there. Put it in another way, the notion of gap that is so central to global mental health only matches the realities of a limited set of places, places that come to compose the globe in global mental health. Different ways to understand suffering and its relief, for example, those that come from social medicine, could produce different ways to understand those gaps, creating different maps or a different sense of the globe. What was important at that point was that there was, in our view, a multi-layer geographical, political, and epistemic absence. And we, as social scientists from Latin America, somehow inhabited this gap, and this sets a process in motion. Lots of discussions came after this, but also the need to do something. We knew that we had to expand the conversation to see if our perception resonated among other researchers. With colleagues' help, we reached out to other Latin American PhD students working in the social science and sharing an interest in mental health. Eventually, a team of 8 was formed, including members from Brazil, Peru, Colombia, and Chile. We had backgrounds in anthropology, sociology, epidemiology, public health, psychoanalysis, and psychology. And at that point, we were based in different universities in London, Paris, or Lisbon. Our PhD projects looked at mental health issues in Chile, Brazil, Peru, Colombia, and Argentina. We set out to transform this encounter into something, an identity. We decided to create the platform for social research on mental health in Latin America. We intuitively agreed that the best starting point was to hold a larger conversation in the form of a workshop, where similarly positioned researchers could know each other's work. Our perceptions resonated not only among PhD students, but also across several scholars who quickly became allies and collaborators, like Dominique Behag, Francisco Ortega right here, and many others, in the UK, Chile, France, and Brazil. With bits of funding from here and there, we organized 2 very successful workshops, one in Paris in 2017 and one in London in 2018, and this allowed us to link up with many other researchers and academics in Latin America, Europe, and North America. Some important questions started to come out after this, questions that are at the heart of what does from the South means, and in what sense it's different from about the South. Since we were all living in Europe at that point, a natural question was how to link these efforts and enthusiasm back to each of our country's realities, how to make space for those voices and concerns, to what extent what we experienced as relevant in the context of our own training in Europe could also be relevant not only for colleagues, but also to workers on the ground, patients, carers, etc. Now, more than a question begging for a concrete answer, I want to point to the question itself, this need to be accountable to people that we were supposedly representing. Our success in creating an interest in Europe was directly proportional to a concern about representation and fidelity at home. Maybe this ambivalence, this being in more than one place, having more than one public in mind, and therefore developing more than one voice is part of what "from the South," quote unquote, means. In practical terms, this concern led us to use most of our funding to help researchers in Latin America to participate in our workshops. And this became kind of a work ethics. This produced a further question. Was plasma a way to bring Latin America to the attention of global mental health, to somehow illuminate that shadow zone? Was this the imbalance that we wanted to address? Even in the way the question was asked, it was clear that the answer was no. We wanted more precisely to produce a dialogue between the different ways in which suffering has been addressed in different parts of the world. We wanted to highlight the specificities and heterogeneity of Latin America vis-a-vis the universalistic ambitions of global mental health, adopting a critical and comparative perspective on the region. We wanted to insist on specificity and heterogeneity as the ground from where another kind of globe could be created, a sort of bottom-up, inductive, tapestry-like globe. To conclude, we choose the name platform very intuitively. Somehow the notion of a network wasn't satisfactory. It seemed too rational or functional, an assortment of self-contained nodes relating to each other in very precise ways with a clear goal. We wanted to create what we needed at that point, and I think is still needed to further the conversation about global health and social medicine, was a space to discuss and reflect collectively on our interests, our needs, and the position that we come to fulfill as social scientists interested in Latin America. A space for things to grow at their own pace. And then, out of curiosity and while preparing for this presentation, I looked at the etymology of platform. Platform is a plan of action, a theme, a design, a ground plan, a drawing, a sketch. Senses now obsolete. From French platform, literally flat form. Recovering the obsolete aspect of the word, a platform is a flat form, a plane, and a space where things can happen, where other forms could be developed. It integrates a temporal and a spatial dimension. It sits in between the abstraction of a model and the concreteness of a territory. It is not there waiting to be discovered. It has to be designed and sustained. As the conversation about global health moves on, and especially during and after COVID, these can be helpful and relevant tools for the task of their rethinking the locations and roles that we still describe as North and South. Thanks.
Thank you, Christian, for this excellent presentation. And now we move to our next speaker, Professor Eugene Reichel, who is a cultural and medical anthropologist whose research interests encompass the social study of science, biomedicine and psychiatry, culture and mental health, addiction and its treatment, biogenetic identity and sociality, and social transformations in Eurasia and the United States. He's an associate professor in the Department of Comparative Human Development at the University of Chicago, where he currently also serves as director of the Center for East European and Eurasian Studies and of the minor in Health and Society. He's the author of Governing Habits, Treating Alcoholism in the Post-Soviet Clinic, published by Cornell University Press in 2016, and the co-editor with William Garriott of Addiction Trajectories, published by Duke University Press in 2013. And he's also the editor of the website Somatosphere. Thank you, Eugene. It's a pleasure to have you here.
Thank you so much to Junko, Francisco, all the organizers for inviting me to take part in this really fascinating conversation. I'll try to keep it, my presentation brief. My contribution today to this discussion will draw from the work that I've done with a number of colleagues on the website that Francisco just mentioned, Somatosphere. And I'm going to use this as a vantage point from which to address the provocation of this this discussion about social medicine and the global South. So what I'd like to think about is the role that what I'm going to call experiments with scholarly infrastructures, and specifically infrastructures of communication and publication, the kinds of projects very much like Somatosphere and also like Plasma that was just presented, the role that those might play in this discussion, broadly conceived. And to be clear, I'm going to focus a bit on Somatosphere, not in any way to argue or suggest that it's been particularly successful in addressing any of these issues, but simply because it's working on this project has been my way into a number of these issues. So I'm going to start by giving a brief background on Somatosphere, and then speaking a bit about these broader issues of scholarly infrastructures, and then very briefly focusing on three key issues of access, language, and collaboration and scholarly relations. A bit of background, Somatosphere, for those who are not familiar, is a website that a number of early career medical anthropologists founded in 2008 in an effort to create a distinct online space for medical anthropology. Most of us at the time were inclined to a particular kind of medical anthropology, one that was closely engaged with questions of epistemology, history, and politics. And for many of us, the neighboring disciplines and problem areas such as science and technology studies and the history of medicine were not only vital sources of inspiration, but domains in which we were interested in developing closer engagements and conversations. And while medical anthropology in many ways has remained at the core of the site, we've increasingly pushed it in the direction of an interdisciplinary focus across the critical and interpretive social sciences and humanities of health and medicine. And I think social medicine is very much part of that mix. Beyond the general orientation of the site, it was not really about, I think, creating an online space in order to promote a very specific argument about what medical anthropology should be, but about generally raising critical questions, debate, and commentary about contemporary and historical matters of science, healing, illness, and the body. And as we continue to work on the site, our collective attention and conversations focused as much on issues of process, of organization, as they did on issues of content. And in some ways, the kind of big argument I'm trying to make here is that this kind of a focus on these infrastructures becomes very central to this and a range of other projects. And I think that paying explicit attention to that is important for thinking about something like a project of thinking about social medicine from the South as well. So in other words, quite early on in the work that the core group on this site did became largely editorial. When we started out, this was a sort of a moment when a lot of blogs were emerging or had emerged a little bit before some of the social media platforms that many of us are on now had emerged. And we were very much trying to do something in that kind of a blog mode. And like others, we wanted work which appeared on the site to occupy some kind of a space between hallway talk and peer-reviewed journals, but there were many niches to potentially develop in the space. We wanted to both take advantage of the technology to publish pieces more quickly than journals, but also to publish contributions that had been given some relative amount of editorial attention. And this meant that we both developed a relatively liberal process of internal review, and that we tried as best as we could to work with contributors on the style and voice of their pieces. And we also worked to expand the size of our editorial team. In 2014, we established an editorial collaborative of scholars who worked together to develop the overall vision for the site. And I'll say most of the initial contributors were based in North America. And while we've tried to make a concerted effort to assemble a geographically broad editorial collaborative and to solicit posts from scholars in a range of countries, there's still much work to do. Zooming out, Sematosphere is really, I think, just one example of a range of projects which have arisen over the past decade in the social and human sciences, and which I would argue have begun to pay an increased attention and increasingly experiment with what we might call scholarly infrastructures and practices. And there's not here time to get into the details, but I think that this kind of heightened focus on these questions in recent years is shaped both by current global political moment, a range of different institutional conditions in and outside of the academy that have been developing for decades, and the affordances of a range of digital communication technologies. And in many ways, I think these dynamics have been amplified by the pandemic. So, and this is just a number of the kind of, I could have included many other examples, a range of different kinds of projects. Some of them are associated with traditional peer-reviewed journals, others with blogs, others like the platform Plasma that we just heard about occupies yet a different kind of a genre. So if we focus just on those projects that are concerned with communication and publication, over the past decade, I think what we've seen is the emergence of an increasingly variegated and heterogeneous archipelago of venues for scholarly communication, ranging from various kinds of book and journal publishers, some of them open access, some of them not, some commercial, others not, to a range of blogs and hybrid websites, and also to interactions among networks on social media, such as Facebook and Twitter. And my point there is just that I think that we have to kind of think of this whole kind of ecology of academic, scholarly, and other kinds of communication and publication across these different forms of these different sites and different kinds of places, and thinking about what this means for the kind of loci of scholarly production and translation. So what does this have to do how does this bear on the questions at the center of our discussion today? I think very briefly, I want to just focus on three key questions or three issues I want to just raise. The first is access. Clearly, questions around, often framed around the open access movement, have been argued to be central in opening up, creating more access globally to different forms of scholarly communication and publication. And obviously, a lot has been written about that. And so I'll just restrict myself to a few points. I think that I found very persuasive arguments made by a number of observers that any kind of conversation around ideas of open access is really incomplete without, again, this broader exploration of how ecologies of scholarly communication, publication, and research are changing, how they're linked to the political economy of the academy. And the idea is basically that we can't really speak about open access and what openness or access might mean without thinking about a host of other issues, such as the models of peer review, relationship between journals and other modes and sites of communication, the role of university libraries, the assessment of academic labor, and of course the questions of where these different projects are situated, and the different kinds of institutional capacities that they might be drawing on. And at the same time, as a number of us argued, a couple of years ago in a collectively authored Sematosphere piece, what is compelling about the kinds of projects that I highlighted in the slide of different kinds of experiments is not so much simply that they're adhering to some kind of open access ethic in a narrow sense, in the sense of contractual agreements in a format of publication. But really what we argued, and this was a piece that a number of us wrote collectively in the sort of aftermath of the Journal How's, the kind of scandals around the Journal How in anthropology. And what we argued is that what we found vital in the most significant open access publishing projects was a kind of dedication to fostering respect and care for divergent communities of scholars, as well as attention to the ingrained and often unremarked upon inequalities that are fundamental to our disciplinary lineages, the material conditions under which we and our colleagues presently labor, and the economies of citation prestige and affiliation that continue to make anthropology and kindred fields hierarchical and exclusionary places. I just wanted to highlight that, I think, as a set of issues, I think that need to be part of this conversation. A couple of really quick points. Issues of language and translation, I think, have been central to thinking about this experimentation in some cases. One series we ran on the site was one in which books published in languages other than English were reviewed as a way of trying to facilitate some of this, at least attention to traditions in social medicine and other social sciences of medicine outside of the English language. Another, I think, important, interesting experiment, a series that was edited by Luisa Reyes Castro called Historias of Zika, was interesting in that it was just published in both, in this case, Portuguese and in English simultaneously, in some cases with Spanish versions of the posts as well. And in a small kind of piece of this was to place the Portuguese language versions at the top of the post. A final note, just about sort of potentials for collaboration and scholarly relations, and thinking about them. I think one of the most interesting, the interesting kinds of projects that we've seen on Sematosphere have been ones that have been involved a range of different scholars. For example, a recent series on making and unmaking medical anthropology around the world, which was co-authored or co-edited by Elizabeth Durham and Pascal Koum-Awa, and really raised, I think, these questions that we're precisely trying to think through in today, but also brought together a series of posts that were all written by collaborators across what we would traditionally think of as global North and global South institutions and fields. So I think just in wrapping up, I want to argue for attention to these questions of infrastructures, scholarly infrastructures, as an important part of thinking about the potential for both thinking about social medicine from the South and thinking about the South in relation to social medicine, and hopefully we can return to some of this and discuss it more in the Q&A. Thanks.
Thank you so much, Eugene. I mean, I really think that your somatosphere has really transformed the way we do medical anthropology, and it has influenced journals as a result. So we really want to go back to some of those questions in our discussion. Our next speaker is Professor Wen-Hua Kuo, who was trained in medicine and science studies. He teaches social medicine at National Yang Ming Chiao Twin University. I'm sure I'm saying it wrong. You can correct me later. In Taiwan, his research revolves around how biomedicine and public health are introduced and practiced in East Asia, and the transformation of Asian medicines as they become modern and global. And I should also add that he's also the editor for East Asian Science, Technology, and Society, which has really, again, transformed the way we do science studies in East Asia.
Hi, thank you very much for having me on this very exciting mini symposium. I'm Wen-Hua Kuo, and as you see in the first slide, I think everybody can see it. I'm the editor-in-chief of the journal called East Asian STS. And I'm always asked what is the meaning or definition of East Asia, just like we're also asked what is the meaning of the South, I mean, as compared to the North. So that is always the question on how to identify ourselves and our journal. I think Eugene already said a lot of good things about like we have to think about scholarly infrastructure. But I want to push a little more by saying something like what should be published there. And we have journals like this one I'm running, but somehow we are trying to make things change. This is about myself, and you can see I'm also the advisory editor of a journal called Tapuya. Tapuya is our sister journal, also published by Routledge. It's a Latin American Science and Technology Society. We have been contacting each other 5 or 6 years ago, and we try to do things together. So the question for me as editor-in-chief is about how to make that possible, or what kind of things should be published. It's not just thing about the East and West or North and South, but somehow to make things, make some exciting things. I think this is the primary goal for any scholarly journals, and also for a scholar for me based in Taiwan. I will always ask like, I mean, why this this journal is based in Taiwan? Is there any larger scale scope for that? And so when I was invited to present something about the North from the South, I'm always thinking about how to identify Taiwan as a part of the South, as Jing says in the case of China, or say we should be the part of the influence by the North. So so let me just take a recent example. Actually, just happened 2 hours ago. That is a travel bubble. It's Asia's first one to 2 COVID-free nations. And interestingly, if you see that the slide here, you can see the first travel bubble was between Taiwan and Palau. And you cannot imagine like why these 2 places, I mean, aparting for, I mean, like 2,200 kilometers. So it's very far. And people really wonder what is the connection of the 2. So I think that is a good way to think about myself as a Taiwanese scholar, and also as a journal, what this journal can serve or can make friends to be part of a scholarly, I mean, infrastructure that fostering, say, like the more collaboration between the North and South, and say to do better things on social medicine. While we have 2 big questions, I don't want to repeat again, but I just come to my mind is just 2 quick responses. Is that I think South for me as a scholar hard to be, I mean, categorized as a North or South. I think South is a proper process in social medicine. I read it can be located in relations, in public health policy, or science diplomacy. And at every moment it invites capital agents and actors, and it can be productive. If you're running a journal, anything related to South can be a very productive thing. They create new ideas, new methods, and new perspectives. I think that's why we have this symposium. And also, I think I will take this the notion of Asia as method. This is a concept we have about like 50 years ago by a Japanese scholar, Takeuchi. And after that, we always think like Asia is not just the subject. It can be a productive method that's just to try to find things missing in the mainstream narratives. So I take this, I would say like to take the South can be made visible conceptually and in practice. What is missing in promise of health on the global scale. I think this is why we bring up the idea of the South. But as a journal editor, I appreciate empirical approach. As I said, we need some friendship, collaboration. But again, as a scholarly, endeavor, we welcome empirical studies, cases. That's just to make our argument stronger is by saying, like, we're not just thinking about like what we can do. By introducing the concept of the South, but they say like what we can do to change our way to look at how the social medicine is practiced. So, well, let's see. So it stopped working. Sorry, I'm not sure whether. Okay. So, the standard way, as I showed, is one of the thematic issues of our journal is about Taiwan. As you can see, as a cover, is a cover of a thematic issue that feature Taiwan in the center. As I say, it's from the war time propaganda called the From Taiwan Stronghold for the South, a photo report. It says that they bore the caption calling the island the center of the great East Asia prosperity sphere. And you can see, like, again, it seems that it's the center, but it can be the South. It's the South from Japanese Empire. I would call this it's a South that led to the South. So you can see the knowledge as was produced, say like tropical medicine, it's a research, and even some pharmaceutical material like chikungunya. But again, Taiwan is a very strategic position that it's not that like sort of like is age of the empire, and to show the possibilities toward the more southern places. And quickly in the Cold War period, you can find like under the Cold War scheme, it become the laboratory. It's a laboratory because at that time Taiwan is a representative of China. It can be a lot of the big countries in the world, and that founded the WHO. So quickly we adopted several public health programs. Like 52 to 55, the malaria eradication program, and the 62 to 66 family planning program. They're successful, as I say, and one of the thematic issue of that is Taiwan be portrayed among with other so-called laboratories in the world. They say like it can be a sort of the case, example to do good international health. So via WHO and US agencies, we just show, say, like how such programs were possible in Asia and Southeast Asia. So you can see in the conference, like it's a conference held in Taipei a long time ago that just fortunately say, like, Taiwan can be a case for other places in Southeast Asia. So in again, Taiwan is a kind of the boundary place where, say, like you always have the connection to the north, but also have a good connection to the south. But quickly, people know, say, like after 1971, we lost the UN seat, and finally we lost a seat in WHO. So the social medicine took the different roles. In Taiwan, because Taiwan kept diplomatic ties with Latin America, Africa, and Southeast Asia by technical aid. So you can see, like, it's a sort of science diplomacy, and that also use medicine as a tool, because as I say, see in the other photo here, Taiwan sent its best medical personnel to Saudi Arabia to secure its supply of oil. That was the early 70s. And a lot of my professors in our university actually were there. I mean, they build hospitals and they make friends and they translate, but it did not save that our diplomatic ties to Saudi Arabia. So that kind of health diplomacy, we called it the South-South cooperations, but it has its politics. And quickly, we moved on to this millennium, the 2000s. I would say like this is the rise of China in Africa, and we lost some countries we have, formal diplomatic relationship. So we changed our role to, more public health missions to Africa and Oceania in the South. This is one of my students. Actually, he helped a lot of people in Africa on the water issues there, and in the early 2000s we have the pandemic like SARS, H1N1, or COVID, and Taiwan created the sort of discourse that Taiwan can be the loophole because we do not have the power to know the information to participate in global health. That puts Taiwan's position in a very weird position because it's not the part of the South, but it's too well to be helped. So it's not like the real South, like you need real help, but it's also too isolated to be asked for help. So you can see that kind of discourse dominate global health in Taiwan. Even now, as you see in the bottom of this slide, you can see the Health for All Taiwan that is produced last year because we're sort of COVID-free. We have the extra face masks. We want to help other countries, but it's still related to our international relations. So just quickly review, Taiwan as a case and how the concept of the South can help us to use it in a different light. Actually, I would say to push a little further about like what the concept of South can help us to know better about the universality and the specificity of in social medicine as in theory or as in practice. I would say like our journal, the ESTS, welcome different kind of new connections or new scholarly infrastructure built for that kind of direction or perspective. For example, we're the first to have the traditional medicine introduced in our journal in terms of global medicine. And we also have a recent issue about care that is in the India, Taiwan, Japan, and further in Malaysia, Southeast Asia. Not saying say like Asia now have a lot of immigrants from other countries, as you say in the bottom, where they are Muslims. Actually, they get together in the main stage in Taipei for the festivals. So that kind of changing phase in Asia just push us as a journal to be open to the world. So a lot of people ask us, what is the geographic meaning of East Asia and its science, technology, and society? I would say like it can be the world if we bring some new concept to it, just like the South. I think I should stop there. Thank you for listening.
Thank you so much for your very thought-provoking presentation. I really love the idea as the South, as a concept, as a way of revealing what's missing in the promise of health at a global scale. We have the last speaker, who is Professor Omar Dewachi, who's Associate Professor of Medical Anthropology at Rutgers University. Before joining Rutgers, Professor Dewachi taught social medicine and global health in Lebanon, where he co-founded the conflict medicine program at the American University of Beirut. Trained in clinical medicine and anthropology, Professor Dewachi's work examines the social, medical, and environmental impacts of decades of war and violence in Iraq and the broader Middle East. His award-winning book, Ungovernable Life, Mandatory Medicine and Statecraft in Iraq, documents the untold history of the rise and fall of Iraq's healthcare under decades of US-led interventions. His forthcoming manuscript, When Wounds Travel, chronicles close to 10 years of ethnographic research and public health work on war and displacement across east of the Mediterranean. More specifically, the work explores the connections among the widespread of conflict-related injuries, multi-drug resistant bacteria, and the reconfigurations of healthcare and humanitarian geographies in Iraq, Syria, and Lebanon under decades of protracted conflicts.
Thank you so much, Junko, for the introduction. And thank you so much for giving me the opportunity to be part of this critical conversation on the theme of global social medicine. In this talk, I reflect on some thematics and experiences of close to 2 decades of engagements in social medicine and global health in Lebanon at the American University of Beirut, where I co-founded and co-directed the conflict medicine program along with my colleague Ghassan Abu Sitta, a British Palestinian reconstructive surgeon with a wide experience in war and trauma surgery. I'm not going to go into the history of this project, something I can maybe comment on more during the discussion. Rather, I will focus on the rationale and problematics that initially inspired us to develop this approach as a practice of social medicine that engages and blurs the relationships between North and South through rethinking biomedicine, its biosocial dimensions and entanglements in the context of the ongoing conflicts in the region. Contemporary protracted conflicts across the Middle East have presented health systems and professionals with unprecedented challenges. Military interventions and conflicts in Iraq, Syria, Libya, and Yemen have taken place in urban settings, resulting in high casualties and injuries among civilians and combatants alike. In fact, the distinction between combatants and civilians have become increasingly blurred, making the injuries they suffer almost similar. In such settings, the delivery of treatment has been often partial and inadequate due to the degradation and targeting of health infrastructure and health professionals. This translates not only in the nature of the wounds inflicted, but also in the limits of the capacity to provide much needed care. Moreover, the massive refugee crises and population movement catalyzed by these conflicts have further put strain on the capacity of neighboring countries' healthcare systems in attempting to absorb the brunt of that burden. With limits of access to care in these geographies of displacement, both in refugee camps and in impoverished urban settings, many of the displaced have found it very difficult to access much needed healthcare. Until recently, the provision of healthcare in war has been shaped largely by the discipline of war surgery, delivered predominantly through Army Medical Corps and by humanitarian organizations such as MSF, Doctors Without Borders, and the ICRC. Indeed, this has its own history in Western war contexts. For example, the emergence of the field of plastic surgery during World War I. However, this expertise has remained concentrated in acute crises and among limited number of Western actors who have faced and are facing increasingly access constraints in these conflicts. In the Middle East, the primary response, however, in the full range of health needs in conflict is not carried by these specific humanitarian or military medical teams working in emergency situations, but rather by entire health systems struggling to adapt to working amidst collapsing health infrastructure. Thus, existing expertise in war surgery is poorly equipped to attend to the multifaceted and complex psychosocial wounding that is characteristics of these conflicts. Unfortunately, advances in military medicine to address changes in war wounds, example as a result of new weapons, have not fully permeated into civilian sphere, even though this is now where the majority of the victims of war are treated. It's important here to assert that there is a long history of experience and expertise in war medicine in the Middle East that has not been really documented very well. Despite recurrent and protracted conflict, much of this knowledge has not been turned or documented into expertise. Here I refer to the 8-year Iran-Iraq war, which is considered as the longest kind of conventional war of the 20th century, mainly during the 1980s, the history of the 15 years of the Lebanese Civil War from 1975 to 1990, and the experience of many international communist medical doctors who worked in the Palestinian camps during the Israeli assaults on Lebanon. War processes alters the biosphere, including the physical infrastructure and the biological and social environments in which people live. These destructive and degrading transformations are often irreversible and have long-term consequences for individuals and society. Thus, conflict-related pathologies are becoming endemic and extend beyond the immediate damage caused by weaponry. Destroyed or degraded sanitation facilitates the microbiological seeding of wounds. The body weakened by the wound is re-injured when it interacts with the harsh physically degraded environment. The social, political, and financial cost of injury and treatment burdens vulnerable families whose livelihood are under strain from war and displacement. So conflict medicine thus requires a systematic approach to address these clinical, social, and public health consequences of contemporary warfare and respond to war's changing ecologies. One critical example of the concern of this conflict medicine is multi-drug resistant bacteria, which now accounts for the majority of war wounds infections across the Middle East region. Reports from civilian, humanitarian, and military institutions have identified multi-drug resistance as the predominant multi-drug resistant bacteria as the predominant pathogens causing infection in these war wounds, yet most facilities in the region do not even have laboratory capacity to diagnose MDR. This has led to significant delays and clinical mismanagement of festering wounds. Moreover, the majority of the dwindling numbers of antibiotics that are effective in treating MDR infections require inpatient care and close monitoring due to their toxic side effects, which further poses huge financial burdens on the families. A second example of the consideration of conflict medicine is addressing how global advances in the management of non-communicable diseases, such as cancer and diabetes, have been reversed in conflict settings. Healthcare systems and technologies are unable to provide the same level of care in harsh and complex war environments. Kidney failure patients can no longer access dialysis units. The delivery of chemotherapy to cancer patients is severely compromised. Diabetic patients struggle to both monitor and adequately manage their diseases. This is further exacerbated by the targeting of medical facilities and the flight and migration of medical experts from conflict areas. A third example is the paradigms of diagnosing and treating mental health consequences of protracted conflicts also need to be visited. The predominance of psychiatric models such as PTSD, which are premised on a temporal exposure to war and trauma, do not hold sway in areas where the everyday lives of entire generations have been shaped by chronic conflicts. At the same time, current models of psychosocial interventions and support need to be rethought to better address the complexities of injuries to the collective psyche and the social body writ large. And one of the other central challenges in terms of expertise has been the kind of the stagnation of medical curricula, especially for people working in settings or basically training in settings of war, where war injury constitutes a big burden of the disease. Unfortunately, due to kind of colonial adaptation of these curricula during kind of period of nation building, or due to this kind of era of neo-colonial medical culture of accreditation, many of the such curricula do not reflect clinical and public health realities in these regions. So there needs to be kind of a rethinking of these these medical training programs to develop a much more suited frameworks and approaches in context of these conflicts. So to conclude, conflict medicine, I believe, is social medicine par excellence. It is a framing, a method, and a practice that needs to be understood through the changing biosocial histories and ecologies of wounds and woundings of war and the attempts to respond to them. In war-torn environments where data collection is nearly impossible, patients' narrative and experiences have become of greater value in providing insights into the early detection of health needs and changing patterns of morbidity. These narratives help in better understanding the ways affected families and communities strategize their survival by triaging their health needs with the resources and facilities available to them. So in highlighting some of these challenges of doing medicine in a conflict setting, I would like to end, for the sake of discussion, by raising a few provocations. So what does it mean to speak of human rights and social justice in a context of war? How can human rights be central to a global social medicine when Western and regional powers continue to pump weaponry and undertake military interventions under the guise of the war on terror? How can social or environmental justice be our compass when millions are displaced and where war ecologies continue to injure and re-injure populations living in these areas? Indeed, the Middle East has been often absent and, dare I say, silenced in the histories and discourses of global health and social medicine. Maybe it's the sensitivities of some of the conflicts in the region that makes it easier to take a position about poverty, suffering, and justice elsewhere. Or maybe there is a deeper unfathomability and messiness of these conflicts that hinder attempts to engage and address war as a global health crisis. Whatever the answers are to these somewhat rhetorical questions, it is critical to resituate conversations on and frames of war and conflicts back in our attempts to think and rethink global social medicine. Thank you very much.
Thank you so much. I mean, I feel like I know so little. I mean, whenever I read your work, I feel like I know so little about what's happening in war zones and also about Middle East in general. And it makes me realize that there's so many people living in a war time or under conflict as a default condition of their life. So thank you so much for your inspiring talk. And now I'd like to move on to our general discussion, and we have already received a few questions. But maybe before we go on to the questions, I'd like to raise sort of a general question that I have for all of you. Partly because I work in Tokyo, and I'm a medical anthropologist working from Tokyo, and it has become so much easier for me to work and communicate with scholars in the North, so to speak, because of the internet and because of this kind of Zoom platform that allows us to communicate without having to travel for 17 hours. But I think it's still very difficult for people, especially people like myself, who is a PhD in teaching at times in medical schools about the meaning of medical anthropology, and also to communicate like what's happening in Japan or in Asia, in places like the UK or in England or elsewhere. So all of you have, some of you were born outside and then are teaching in the US. Some of you are teaching and working outside the US or UK. What do you, and I know among the audience, there are many scholars, young scholars, who are trying to make their ideas heard in those context. And also across disciplines from social sciences to medicine. So they're not only working with the barriers of the geographical barriers, but also disciplinary barriers. So I just wanted to get a sense of how you think they can overcome these barriers. And some of you have created wonderful platforms like Somatosphere and other journals. But what can we do next to make it even easier to create this kind of dialogue? So anyone can, if you have any ideas. Or maybe can I ask each one of you to say a few words about that?
Okay, can I say first?
Please, thank you.
Okay, I know it's a challenging question how to generate material that can cover the north and the south. I just to share with you one of the things our journal is good. Doing was our sister journal Tapuya. We started with a mini project called literature review, but it's a review about reproductive technology used in the world. Our goal is just to, recover some of the missing literature by mainstream, literature scholarship. So the goal is clear because at that time we already have a so-called the global health or global reproductive technology book recently published, but we feel like we can say something more. So we had some conversation with the editor of the Tapuya, and then we started to collecting literature from Asian perspective, and they will collective literature from the Latin America. We do not know what will happen because we haven't go through with what kind of frame we're going to do, but I will take it as an interesting, exciting challenge because somehow you will never know. We were discussing like we're too far away or cannot do things together. That's why we just sit together like today, and we can generate something that can be turned out to be very exciting. Yeah.
Thank you. Anybody else?
I guess really quick, I think that one thought I have is I think that we need more concerted efforts like the really interesting one I saw circulated recently that this group is doing, or a number of journals are doing. Maybe some of you can talk about that to facilitate. I think there was a workshop between Medical Anthropology Quarterly, Transcultural Psychiatry, and a few others focused on scholars from Latin America. So that kind of concerted project, I think, is really excellent, and I think creating spaces, right, where we can sort of unopen some of the black boxes around what how to enter certain kinds of conversations or get things published in particular platforms. But then the other thing I would just highlight is, there have been a lot of really interesting projects, especially that have popped up over the last year. Something like the Corona Times blog, which is a project, a collaborative project between the Institute for Humanities in Africa at the University of Cape Town with a university in Norway and Sweden, and did some really interesting early and has continued publishing pieces about coronavirus, just in the sense that like there are these tools, right, these platforms that are available, and starting something of your own is an option, right? It's not. I don't want to understate and just say like, oh, it's just a flat kind of a landscape in which anyone can enter, and to deny the kind of hierarchies that are existing. But at the same time, those platforms are out there, and I think they're quite powerful.
Thank you.
I can say a few things.
Please.
Actually, one of the main challenges for me working in Beirut and with other colleagues has been kind of issues of funding. So there is a big problem with how, when you kind of have ideas of research and you want to kind of, especially kind of these bigger projects where you want to do a more sustainable long-term investment in thinking about a problem and following it as kind of as a cohort studies, is the need for being always dependent on Western institutions and Western universities. So we bring the ideas, but the name of the project becomes under a certain kind of under kind of certain umbrella of a different universities in the US or in Europe or of that. So there's that kind of issue that becomes a little bit tricky. I mean, not that there is a problem interpersonal because people know these issues, but at the end of the day, a lot of that credit ends up being kind of kind of framed, I guess, or misunderstood. And I think one way to think about is how we can not necessarily support writers and scholars, but also support kind of projects of long-term research projects in areas what we can call the global south.
Thanks.
Could I?
Yes, Christian, please.
Yeah, sorry. So just because it's very related to what Omar is saying, something that happens in our countries like Chile and Argentina is that we do have some funding to do stuff nationally, but we have no funding to do any comparative kind of work. So to do comparisons between Chile, Brazil, and Ecuador, for example, then we need to rely on the north, So the comparative is kind of blocked, and we are pretty much limited to insist on what happened to nationally, because the funds are national, they're not much funding, and they prioritize, of course, national problems. So I think that's kind of I mean, in order to develop a more comparative, integrated vision of issues, that could be a very helpful thing. And in a way, creating Plasma was also a way to have contacts in those places that are very near us, but places we don't have other ways to understand. To have someone in Brazil, to have someone in Peru. So instead of doing like a comparative project, then you better create like a network of people that is based on those places. Of course, creating networks and creating groups of people is a whole different sort of issue, It also requires maybe patience. You depend on the time that people has. Everyone's agenda is different. In our case, we were finishing our PhDs. And while we were doing that, we had time to invest on this, but then on like searching for jobs, coming back to our countries, settling in. Of course, we didn't have much time, or maybe one of us had time and not the other. So that's the difference between kind of a natural group and an institution, So there are things that you can do with a group. It fluctuates a lot, and there are things that you can do with institutions where it's much more predictable. Funding is more predictable. You have certain times of the year. So I think maybe something that we will need to do is how to work with these both tools, Like on the one hand, creating interactions, creating relations, holding discussions, relying on the natural development of communities, and on the other hand, considering what institutions can offer, and that includes universities, that includes traditional journals, that includes funders. You will need to look with both lenses at the same time. So maybe that's something that we need to consider.
Thank you. I think it's really helpful to have these kind of communities across the world, because sometimes what younger scholars need is that kind of mentorship, somebody who's had that kind of trajectories and can share ideas about how one begins to be heard. But because we have, I think, two excellent, yes, please.
Oh, sorry. I just want to say very quick, a few words to that question. well, as a junior female scholar myself, and also born and did part of my education outside of the US. I think I am with some other folks here who share the kind of ambiguous position, right? On the one hand, certainly I am still sort of like in a position sort of vulnerability in the kind of US academia, but on the other hand, I think I and several people here are in the position of privilege, right, in comparison to a lot of our interlocutors in the countries that we study. So I think I don't have as many collaborations with scholars in China where I do my work as with actually activists and community members, because I'm actually, besides my academic work, I'm very much involved in the disability rights movement there. So I've been working with folks in that realm. So I think for them, knowledge production and means a lot of different things, and we need to think very carefully about whether like publication in an Anglophone journal is something desirable to them, right? And if that is, and I have done something in that regard. For example, recently I have co-written an article on how blind people struggle for the rights of to access the mainstream college examination with a blind activist himself. And so because I think we share a common concern with current advocacy strategy, etc. And we hope to, by writing that article, be able to have dialogues with other folks who are doing advocacy in other countries. So that's something that we could do. But also, like, publishing might not be valuable to other folks that I work with, right? So I think in that realm, I keep thinking about, in the feminist circle, people keep talking about, well, like there's an old saying by Andre Lorde about like, is it ever helpful to, how can we destroy the master's house with the master's tools? But maybe we could think creatively about like stealing the master's tools from the master's house to do something creative for the community. So I've been doing some of that as many people here on the panel. For example, I have like actually upon invitation of local stakeholders been using funding from my own institution to try to develop a mental health peer support program in South China. And also I have been using another source of funding from my own institution to work with parent NGO to study the needs and needs of and services for children with disabilities in rural China. And that actually, I think, is very helpful to that organization and other similar organizations, because they're mostly located in urban areas and they don't have the resources or usually the motivation to go to rural areas to listen to what their peers are experiencing, thinking, etc. So that project is, I think, not just beneficial to myself, but also beneficial to my friends and the community. But I think the difficulty, there are difficulties. One is definitely, as I think Professor Dewachi has said, the funding limitation. I think institutional funding, especially academic project funding, is just so little, and its timing is just so short. Like, for example, a peer support project, we've hired people to become peer support trainers, peer supporters, and they're so proud of what they're doing, but like the project is only 2 years. What happened afterwards, right? So, I mean, I find myself hustling for funding for them. So that is certainly one difficulty. And the second difficulty is, if we really work with local stakeholders, a lot of times I find that I'm in the co-authorship mode, I'm on different projects. So that sort of really challenges the very like ideal in both, I think, anthropology, but also in other humanistic social sciences, about doing a monographical project, single author monograph, right? So I'm fine with my first project, but I really need to think about how to like tie all of these together to become to make it a monograph for my second project, but I think it might be a common difficulty for all of us. Thanks.
Thank you. Francisco?
Yes, so I go now to the audience. We have here 5, 6 questions. So some of them, there have been a discussion here already on the questions and answers, but I think it's good to raise the questions so the people who didn't read it, they can follow the conversation. So the first question was raised by Ayo Walber, who asked, "Thank you so much, Xin, for your talk and your work. I very much agree with you that the need to move away from unhelpful receiver-centered tropes when it comes to knowledge about medicine and mental health. Wherever we are, we should always carry out our research from the vantage point of those who work with to understand how certain health problems come to be understood and addressed, often involving multiple forms of knowledge, whether global or local. My question is whether the translation or reshaping work that goes into making knowledge relevant that you conclude with some reflections on only applies to global knowledge or perhaps also forms of knowledge that circulate within China. The same question, of course, could be asked wherever we are in the world." So, Xin, it's a question for you.
Right. Thank you very much for that question. And I already tried to briefly respond to that in the chat. So maybe I'll say just a few words and then leave that same question to other panelists. I think it's totally right. We need to think about not only the diversities, but also hierarchies within the South. And especially when we talk about violence and symbolic hegemony imposed by the global North, we also need to think about the state violence that often is inflicted by various state agencies in the North, right, in the South, right, and different theories of the South because of their different locations would have different weight. So I raised the example in my response that, for example, the Chinese state, like I said, is trying to rebuild the community mental health infrastructure, but its legitimation is by thinking of people with mental illnesses as risk of violence to the public. So I very much am aware of the harm, and I am paying attention to how people with mental illnesses and their families are pushing back on this discourse. So yeah, I mean, I'm interested in listening to others and how to think more about the rifts and hierarchies in the South.
So does anybody want to add something to that question? No? Okay, we move to the next question. There are 2 questions that I think they are related. So I'm going to pose it together so we can have more time to discussion. So somebody's asking, there's no name. There seem to be so many levels and layers of political, social, and epistemic hierarchies at play in the questions topics raised. The hierarchy of power of elite institutions in the global North and their role training many leading researchers originating in the global South. Hierarchies between researchers and service users, survivors, which play out between global regions, but also within high-income countries, low and middle-income countries. There are hierarchies of a different kind between academically trained researchers and community members or co-researchers, independent of global region. Often it seems to me that we end up privileging or addressing one set of these hierarchies while neglecting others. What are the panelists' thoughts on ways forward? How can we better do justice to these levels and layers of inherent power, knowledge, and influence over discourse? And there is a question about language, which I think somehow is related. That's why I'm gonna raise as well. Would love to hear more on everyone's thoughts in the Q&A. Another dimension here is language and access. The global South includes huge numbers of individuals with low or no literacy who do not speak or read English, etc. This is even more true of many community-based activists and service users, and of course, those who have faced myriad barriers to education. Many of the featured projects, including Somatosphere, are powerful and yet often accessible to only an elite few. How do we think about and reconcile this? So, questions to all of you. Who wants to answer them?
Just one really quick thought, or a kind of gesture towards something that I think addresses both the first question you raised and then some of the issues that Jing just raised. I think broadly, especially for those of us in the kinds of institutions that tend to valorize conceptual or theoretical sort of innovation over what is called applied or engaged work, or even the notion that those two should be put in separate kind of categories. I think pushing collectively back against that is an important kind of a project. You know, and part of that may be making it so that the academic monograph is not necessarily seen in certain domains as the only path to tenure, which then allows you to translate to valorizing kinds of projects that are less extractive and where people can have different forms of engagement and writing and don't feel incentivized to do a certain kind of writing that may not translate or make a lot of sense in a local setting.
Maybe I can add something to about this. This is, I think, it's a very challenging question, of course. My way of seeing this is that the asymmetries that matter are different in different places, and we cannot tackle all of them at the same time, in a way, because that could create a kind of a blockage or the feeling that is just too hard to even try, in a way, because of course all of those things intersect. But maybe this is a misrepresentation, but my feeling is that in different places you will have orders of priority. For example, in places like Latin America, social medicine is so relevant because there are still many inequities in the distribution of healthcare resources, in the distribution of everything, basically. So other concerns, kind of a post-institutional concerns, we are relevant, but at the same time, we need to put them in a certain order in order to address them, in order to tackle them. Maybe this could be called a strategy, I don't know, and it's hard to be strategic, but I think you need some kind of graduality to break these things down a little bit in order to address them. I don't know if that makes sense, but that's my view.
Okay. Can I join? I would say, like, I totally agree with that, and I would say, like, this is a big question, but you have to separate into several parts, and you have to have that point to start with. So as a journal editor, I would say, like, our journal actually started with a debate about, like, why this journal is publishing in English, not other East Asian languages. I would say, like, this is a point we start with. We care about East Asian languages, so we have like a dual abstract, so like people can submit, their English abstract with their East Asian abstract. But somehow the common language is English, just like Jing say. Like we utilize what is from the mainstream, right? We use this language for our own good. So we use English, but I know it's not the politics in Latin America where you have like Portuguese and the Spanish. So there are different ways to deal with that. But I would say, like, we should not stop there. We have to keep moving forward. So I think this is my attitude towards, say, like, what is a scholarly movement is to change things.
So does anybody want to jump in? I just want to say something about what just when Hua said about the language, because that is a very tricky issue. I see that in Brazil, I mean, where you have, 210 million Portuguese speakers, and a huge audience, many articles published in Portuguese, they got more citations than if they were published in English, because the audience is huge. Some of them, and at the same time, you have at universities, etc., huge pressure to publish in English. And there are people who work with very, very topics that are only interesting in the country or in the area. People working with, for instance, health policies for one specific region of Brazil. There is no interest in publish that in English. I mean, who is the audience who's going to be read the paper? So they just, it's a very important issue. And when you are in these regions, you always have to struggle with that. At the same time, some very important, for instance, in the field where I work, mental health, there is a lot of very interesting community mental health innovations in Brazil that they don't get enough attention worldwide because they were published in Portuguese. So this is also the need to publish in English in order people can learn from that for interesting things that are going on in the country. So that is an important thing. So let's move to the next question from Raúl Necochea for Christian. Gracias, Dr. Montenegro. Speaking of provocations, what could be the worst that could happen if Latin America research priorities were not represented among those set by other global mental health colleagues? Could policies stall? Could services not be provided? Could Latin Americans stop meeting and discussing our research among us? Can you or other panelists think of alternative ways to make Southern priorities and insights relevant to other publics? Christian.
Well, as I tried to answer Raúl in the chat because I wasn't exactly sure about the question. I don't know if it's based on something that I said or not. What I would say, I think it's also, depending on how you frame this question, how you think of alternative ways to make Southern priorities and insights relevant to other publics. I think this is an interesting question because it's very practical in a way. Something that I think is very valuable, for example, is writing literature reviews about non-Western intellectual traditions, but in English. So using English strategically to raise awareness of the amount of things that are being happening and developing for years in other parts of the world. I think, again, social medicine is a great example of this because there is a long list of authors writing about Latin American traditions in English. And I think you could do that for many other intellectual traditions. And I think this is also, just to finish this, it's also important to consider that when you are trying to make sense of a context that is not your context, and when you are trying to understand what is happening, it's not only an issue of the complexities of those contexts, it's an issue of the fact that in those contexts, there are already intellectual traditions that are trying to make sense of themselves. So you also need to deal with that. It's not just the complexity of disease, the complexity of policy. It's also the fact that places create their own self-representations. And this is, and through history, this is, I mean, you will need to give some time also to that, to relate with local scholars, local intellectuals. So I think that this, like writing about local traditions in English, like presenting this, is not kind of imperialist submission, because what you're trying to do, for example, when I write in English, I'm writing to Xi Ying, I'm writing to Wenhua, I'm writing to Omar. I'm not writing just for North American or British researchers. I'm trying to reach kind of a more globally, to people in India, to people in Indonesia. So yeah, I mean, I don't know if that answered Raúl's questions, but that's my thought.
That is an excellent point, Christian, and that reminds me of a very important issue that getting access to this global audience and to these big journals is not only a question of writing in English. It's also a question of adapting to some practices of citing and theories, etc. So papers from the Global South are very welcome about the data, the description of practices, the ethnography, but the authors that are being cited are theories. Your theoretical background has to be the important authors from the Global North. So when you cited many people from, like Latin American philosophers or whatever, many times they are not accepted. I mean, you need to you have to cite Judith Butler and not somebody from Chile or from. So that is also a barrier, and that produces also a standardization in the way of producing knowledge, which is something important. So related to that, in the chat, David writes, some journals have been willing to allow authors to publish the same article in different languages in different journals, but this is not yet a standard practice. Something like this would likely be needed to allow our conversation to engage all audiences. That is a good point. So there is two more issues here on the questions. Shoan Jisheon, who said, love this discussion. This is not only about creating forums or bridging distance to facilitate these north-south links, but I've been thinking a lot about the emerging creative interdisciplinarity that the Zoom world is going to create for future scholarships. Hierarchies within disciplines about which knowledge counts, I hope, will be dismantled simply by being able to access schools of thought outside of one's own institution. So that is also a point. Does anyone wants to comment? It's not a specific question, it's just a point that has also been raised by others. So then we have another question. Lisa Nuse, thank you for all the presentations. Omar, I appreciated your comment on the issue of war being an issue of health. It seems so obvious and a crisis which should be taken up in social medicine. And the silence you speak of it, a blight on the discipline. In the panel on Friday, the issue of naming capitalist and imperialist systems and their role in creating the global North and South and the health disparities therein was raised. I wonder if you could elaborate on the relationship between social medicine and anti-war movements, both past and present and going forward. Question for you, Omar.
Thank you so much. This is an excellent question. So I'll answer by giving a little bit of an examples of what has happened before. So one interesting case to think about how social medicine and health became a kind of a platform for anti-war movement was the 1990s sanctions on Iraq. So we're talking about the destruction of Iraq's infrastructure during the 90s and imposition of probably one of the harshest systems of economic sanctions ever imposed on a country in recent modern history. And one of the things because the sanctions were used as a justification that this was not war, these were kind of just embargoes. These are economic embargoes, but the really ramification of what had been called an invisible war was health, because this is where you see the rapid deterioration of health. Infant mortality in Iraq doubled. Maternal mortality doubled. People kind of went into incredible poverty. Inflation of the Iraqi dinar happened during that period, and despite that problem, and there were really incredible attempts to bring in public health and social medicine as a kind of the kind of the perspective from which we can understand the effects of these interventions. But unfortunately, these were really not that impactful. I mean, the famous Madeleine Albright kind of saying of like, is it worth it to have 500,000 Iraqi kids die because of these sanctions, and saying that it is worth it, was kind of emblematic of these 12 years of sanctions. The other kind of example I would like to other examples, I mean, of course, the Iraq War in 2003 was it rallied the greatest demonstrations seen in also recent history globally across all parts of the world. But all of this did not in any way manage to deter or kind of change the direction of the war. The third example is the example of the war in Syria, which has now, it's still ongoing, and it's now entered its 10th year. During this conflict, the main obsession right now with kind of the social medicine and the global health discourse is the attacks on healthcare, and of course there's a lot of work on showing the suffering of the refugees, but the obsession is the idea that medicine should be neutral in conflicts, and the kind of the highlighting of healthcare attacks on healthcare has been the main issue. So and this is basically comes under the notion that war needs to be neutral when it comes to medicine. Some of the attempts that we've been trying to show is this using the environmental problems emerging from war, like the rise of antimicrobial resistance due to toxic remnants of war, and heavy metal contamination of the environment, which has been kind of pushing a lot of, I mean, at least kind of speculatively pushing a lot of the antimicrobial resistance, and I think kind of using these kind of arguments and showing health outcomes has the potential of doing things, but unfortunately we haven't seen any changes or any kind of success, I guess, in doing that. The depleted uranium story, there was a lot of activism around the use of depleted uranium in the 90s and in the recent wars, and when and its effects on congenital anomalies, it effects on kind of long-term cancer. But the problem, you can't really prove this through evidence, because you cannot really conduct research in these areas, proper research. All of the research that's been done by local Iraqis has been completely, brushed away, partly because it really contradicts with the kind of more, a kind of a more, let's say, an imperialist agenda of these big Western powers, but also because the research is weak. It's not really a very kind of, it's not really strong research. We did kind of a recent systematic review of depleted uranium research, and it showed that there's a lot of problems with even the methodologies that are being used. So this keeps on producing the ambiguities and this what I was calling unfathomability of these war zones. How to move forward with this? I've grown up in conflict areas from the 80s war to the 90s to the 2003 to the ISIS war to the ongoing kind of problems. It's very kind of you become disenchanted with any kind of hope in many ways, but of course you keep that hope, you keep hanging to something that maybe something will change. But I think definitely there is a place, and it's a very important platform to use health and social medicine as a kind of a main anti-war conversation, mainly because these are, in terms of Geneva Conventions, war does impact kind of civilians, and especially right now what we're seeing in these conflicts is that civilians take on the major brunt of the burden of these conflicts.
So does anyone to comment on that? Otherwise,
can I actually, maybe from the Latin American perspective, I mean, the war in Colombia, for example, I mean, you rarely hear a lot of kind of engagement in terms of social medicine in relationship to that. So I'm curious of how kind of our colleagues think about that.
Christian, do you want to comment on that?
No, I don't think I'm able to comment. I know people that could comment, definitely. And I think as far as I see, you are right in the sense that social medicines focus hasn't been on conflict necessarily, or conflict understood as kind of a very clear, sustained kind of territorial conflictivity, and more on a kind of the conflictivity of capital and in general. So, but even saying that is kind of out of my knowledge.
Sebastián Fonseca, who is here and who wrote a great dissertation on the history of the Latin American social medicine, said on the great comment, Omar, on the war in Colombia, there are people that had worked on this. Saul Franco from the Latin American Association of Social Medicine is a key author, unfortunately not in English. So there is a lot of tradition of health workers and primary healthcare workers working with this in these conflict areas in Colombia with displaced population, etc. So I think they have. So I think we have come to the end of our discussion. There are no more questions. It's already 2 hours. So I just hand on to Junko to make the last comments, say the last words.
Thank you, Francisco. I just want to mention that Dr. Wakatsuki, who's one of the founders of Community in Social Medicine in Japan, was going into the villages, teaching farmers how to care for their bodies, because he really saw this as an act of peace, because he remembered, and he was in the war, and he saw how people had no regard for their bodies, which also translated into no regard for others' bodies. And that's what you need to kill each other, right? So for him, taking care of oneself was really a way of ensuring that there will be no more war. So I think in that sense, taking care of health, thinking about health, protecting health, and promoting medicine, social medicine, is really, in the same spirit that Omar was talking about. So I really hope, this has been such a wonderful conversation. It's been very stimulating, productive, and generative. And I think we should give our panelists another round of thanks for providing such a rich set of responses for us to think with today. And finally, I'd like to remind everyone that this is only the beginning, and that this conversation continues with for more workshop. Actually, we have a workshop coming up on May 10th, Social Medicine Writing and Publishing Workshop, which is really designed specifically to help young scholars in Latin America to produce something, to help produce the kind of work that can get published in English in prestigious journals. And this is going to be led by editors of Biosocieties, Economy and Society, Medical Anthropology Quarterly, Transcultural Psychiatry, and the Bulletin of the History of Medicine. So this is an exciting opportunity, and I hope this is one of the many beginnings of this endeavor. So we look forward to seeing you at the workshop as well. So I like to thank all of you again, the panelists and also the audience, for joining us today. Thank you so much.